Welcome to this episode of The Stupid Cancer Show. I'm Alison Silberman, the CEO of Stupid Cancer. Today we're going to be talking about genetics and genomics in cancer care. But first I'd like to thank Genomic Health for supporting this episode. I'm here today with Dr. Patrick Borgen.
Good morning.
He's the director of the Maimonides Breast Center and chair of the Department of Surgery at Maimonides. Thank you for joining us today.
Thank you for inviting me. I'm excited to be here.
So we hear a lot about genetics and genomics, and a lot of the time these two terms are used interchangeably. Can you explain to us what the difference is? And how does this affect our patients? How should adolescents and young adults think about genetics and genomics?
Right. So it's a great question. And to really understand it, you have to realize that less than 20 years ago, we understood cancer by looking through a microscope and looking at the shapes of cells and blood cells and muscle cells. And we made all sorts of determination based on the morphology, based on what we saw down the microscope. This is a good cancer, this is a bad cancer. And that was the best we had. There was no other, but it was a purely descriptive understanding of the disease. So fast forward 20 years to today, and we have both genetics and genomics, which move our understanding of cancer and how to treat it and how to cure it to the next level. So let's start with genetics. Mm-hmm. Fundamentally, genetics is a study of inheritance. It's how traits are passed from generation to generation to generation. And that could be personality, short-temperedness, red hair, big feet. All of that is controlled through our genes by genetics. It turns out that there are a small number of human illnesses which can be caused by sometimes a single gene. So in the case of breast cancer, the genetics revolve around a small handful of genes where there's an anomaly in the gene that's passed from generation to generation. So for example, BRCA1 and BRCA2 are genetic issues, and you're inheriting a predisposition to breast or ovarian cancer and sometimes others from your mother's side or your father's side. Those are important because they can help us predict the risk of developing breast cancer. They can help us predict the risk of developing ovarian cancer. But now they can also be targets for treatment. So genetics are really, really important.
And how does genomics inform these types of targeted therapies and treatment?
Yeah.
Can you talk a little more specifically about this other piece of genetics that help our patients?
So it turns out that our bodies have protective mechanisms, one of which is a group of genes called Tumor suppressor genes. You can imagine that with the billions and trillions of cells dividing in our body, those divisions won't always be perfect. And so tumor suppressor genes that we're inheriting through our family tree identify damaged DNA, they identify damaged cells, and they either fix the damage or they kill the cell. And by doing that, they have a profound effect on preventing, in this case, breast and ovarian cancer. It turns out that those mechanisms that don't work very well are great targets for therapy for breast cancer in particular. So there's a class of drugs called PARP, P-A-R-P inhibitors, which have been found to work extraordinarily well in men and women who have these damaged BRCA genes. Through a mechanism called synthetic lethality, it's a 1-2 punch. It's something that the cancer cell can't overcome. So not only about inheriting the risk of these diseases, but now a very attractive target for therapy.
Great, that's very interesting. You talked a little bit about these, the PARP inhibitors and the specific BRCA gene. Are there other things that our breast cancer patients should know about when they're talking to their care teams about genetic treatments and targeted therapies?
So we need to learn more. We haven't identified nearly enough of the families that are silently carrying BRCA1 or BRCA2 mutations. So What we look for in the family history is young age of development of breast cancer. Breast cancer in both breasts, bilateral breast cancer. Male breast cancer is a red flag. And of course, if you have breast and ovarian cancer in the same family. There are subgroups of women, in particular, like Eastern European or Ashkenazi Jewish women, who have a much higher incidence of having BRCA1 and BRCA2 mutations. So any breast cancer in an Ashkenazi family should raise a flag for the possibility of a BRCA gene mutation.
Okay. And can you talk a little bit about genetic testing, what our community should know about it, what sort of risks are involved, and any technologies that have come over time that might be important for any adolescent or young adult who's facing a cancer diagnosis?
So we're still in the genetics box, and for many years a single company held the patent on gene testing and the mutations and the proteins. A number of years ago, the U.S. Supreme Court lifted that patent protection. So there are a number of very serious companies that are offering commercial testing for BRCA1 and BRCA2. And as you'd expect, the cost of it has come down. They've broadened the panels beyond just BRCA1 and 2 to 8 or 10 or 20 or 30 different genes that can be tested for. So part of what you want to talk to your doctor about is, do I fit the profile of someone who might be tested? And if so, what should I be tested for? So that's really important. The test can be done with saliva or blood, and they're extremely accurate.
Is there something that our patient should know when going in for that testing, and say it comes back with information they're a carrier for BRCA1 or 2 or some other sort of genetic anomaly?
We believe very profoundly that this should be done with an expert, whether it's a physician who really understands BRCA1 and 2, or whether it's a genetic counselor. One of the challenges this country faces is there's a huge national shortage of genetic counselors. And so this information should be interpreted with an expert. There are things called variants of unknown significance, VUSs, and these can be very confusing in the report, and they can frankly be misinterpreted. So some of this is a conversation that should occur before the testing is done. What are we going to do if we find a mutation? What are we going to do if we don't find a mutation? And that's important. But once the test is back, we also have to have someone to process the information with. Let's say, God forbid, our patient has a BRCA1 mutation. What are her options? What should she be doing? What should she be concerned about? Can she prevent ovarian cancer? Can she prevent breast cancer? These are really important conversations.
Okay, so let's talk a little bit about genomics. How does that inform the way that we approach genetic testing and the understanding of genetics?
It's really great to talk about genetics and genomics in the same conversation, because genomics is very different. Genomics is really the study of all of our genes. You've heard of the Human Genome Project, where they took our DNA and they sequenced it across 27,000 genes. An amazing piece of work. But now we can do that quickly and easily. And so the genomics is defined as the study of all of our genes. And furthermore, it's a study of what our genes are saying. And so at one extreme of genomics, we can look across virtually all of the genes in the genome and look for targets of therapy. What is this breast cancer relying on that I can intervene? Is there an Achilles heel to this breast cancer where I can give a targeted agent based on the genomics and knock this cancer off the rails? And that's one of the most exciting areas of research. On a smaller scale, we can look at panels of genes, 21 genes, for example, where we get the expression of those genes. And it's incredibly informative about how we can treat a breast cancer successfully. One of the biggest advances of this decade has been the identification that not all women benefit from chemotherapy. In the decade of the 1990s, every single woman with a breast cancer bigger than 1 centimeter had chemotherapy. And that was based on trials that were done where tens of thousands of women were randomized to chemo or no chemo, and there was a small survival benefit. But when you applied that survival benefit to the United States, there were thousands of women whose lives were saved. But we were giving 100 women chemo to help 5 or to help 6. Genomics has allowed us to identify women who won't benefit from chemo. For example, they'll get all their benefit from a pill, from blocking estrogen. So we have the potential of reducing chemotherapy use, unnecessary use, by 60%, which is unbelievable. That's genomics at its finest.
So for our community, the young adults, women and men who go into their doctor's offices, and all of a sudden these conversations about genetics and genomics and testing are going on, what would you recommend they say to their doctors? How should they approach it with their doctors?
Yeah, great question. You have to be your own advocate in this world. And so asking about genetics, the American Society of Breast Surgeons within this calendar year came out with a startling recommendation that all newly diagnosed women with breast cancer be tested for the breast cancer genes, all women. And this is a reaction to the fact that the guidelines we have for testing miss 40% of families with the gene. And so whether or not we will apply the American Society of Breast Surgery's recommendations, whether we have the resources to do that is a philosophical question. But the idea is we need to test more people. It's often too late when we find that there's a gene. So ask your doctor, do I qualify for genetic testing? And similarly, if it's a breast cancer conversation, how does genomics help me? Do I qualify for the genomic profiles that are out there? Will it help in our treatment? Might it change our treatment? So the genetics and the genomics question should be asked by every patient who gets a new diagnosis.
I love that message of advocating for yourself. That's something we
Yeah,
talk
it's
a lot
really
about
important.
with our community.
Yeah.
And a
Yeah.
great point to end on. Thank you
Yeah,
so much.
thank you for
Dr.
inviting
Borgen.
me. Thank you very much.
Thank you.
Thank you.
Thank you for watching this episode of The Stupid Cancer Show, and thank you to Genomic Health for supporting.